So from my point of view, it's very disheartening.
But it's very heartening that you have the views that you have.
Well, I mean, one could argue that you say it's heartening because of your unique biases and perspectives.
Yeah.
And I'm not arguing that. I'm saying,
I know you're not.
you know, I'm just saying that different people would have different perspectives,
yeah.
different views.
Yeah.
Somebody else would say that if, and I'm not arguing this because I just want to be clear on one thing. All of this evidence about light anesthesia and delirium, this is very preliminary stuff. It's not as if we have, you know, people are adopting these ironclad positions as if this is now firmly established, and
Correct.
it's by no means firmly established. But if it were, let's say it were firmly established that giving deep anesthesia was resulting in increased 30-day mortality, if that were established, then you would have a different scenario, and then you'd need to enter into a different contract with patients to say, look, you know, we're in difficult bind over here.
Yeah.
We want to ensure that you're unconscious for your surgery, but there is strong evidence emerging that the more anesthesia we give you, the more likely you are to be dead 30 days or 1 year after the surgery. We're not there, but if we were there, then it changes the calculus and it changes the conversation.
But I would say this in response to that. We need to start introducing surgeons into the dialogue because I asked one of the experts, he commented robotic surgery, absolute no movement. And I said, okay, what's the justification for robotic surgery? He said infection. I can imagine how long it took the surgeons to figure out that infection was decreased with robotic surgery. The point being that, let's say we get to that point, the issue comes into the vast majority of surgery is quality of life surgery. It's important to give appropriate informed consent to patients in terms of what if we start using light techniques again and across the board paralysis, then the patients need to be exposed to maybe a more open discussion of the need for that particular surgery, especially if it's end-of-life surgery in terms of quality, or middle-aged people having completely unnecessary but quality of life enhancing surgery. The anesthesia part of it it tends to be damped down.
I agree with you. And there are all sorts of reasons for that, including power dynamics and
Precisely.
you know, all true.
Yeah.
All true.
Can you just amplify the power dynamics?
Well, I mean, I think that the power dynamics in relation to surgery are that, you know, like it or not, the surgeons wield more power in the perioperative setting than other members of the team. They're more involved in deciding with the patients whether or not the patients have the surgery in the first place. It's very unusual that an anesthetist or anesthesiologist will have a major impact on that. You know, usually the decision is already made one way or the other by then. And you know, for an anesthetist to talk to a patient on the morning of surgery about, you know, this is, you know, have you thought about the quality of life implications? Is this really, you know, what's the evidence behind this kind of surgery? That's politically very tricky. And you know,
Michael, you've practiced in London,
yes,
as
I have.
well as in the United States. And have you practiced in South Africa as well?
I've practiced in 3 continents, absolutely.
Do
And
you
in different settings I've practiced in.
Is there any variation in this dynamic within the operating room?
There is, you know, I think certainly in the United States, the politics is perhaps more skewed towards the surgeon and the power dynamic than in South Africa or the UK. I think there's also a difference in, for example, the NHS and private practice. So I would often see in the NHS where if an anaesthetist worked with the same surgeon in private practice, she or he would be pretty reluctant to gainsay that surgeon in the NHS practice because they're reluctant to lose their private practice. So there are other interesting power dynamics in the NHS that I notice. So I would actually say that on the other hand, so you see that other extreme in the NHS. In the NHS, your anaesthetist who's doing private work is entirely and completely beholden unto that particular surgeon. And if you piss that surgeon off, you lose your private list.
Yeah.
You know, so you don't get into it with that surgeon.
But not all not all anaesthetists in the United Kingdom are working with the same surgeon.
Not all, but many times that is the case. That is many times the case. And you know, in the United States, where I work, yeah, sure, you know, the surgeons have some power or whatever, and that is the case. But you know, they don't have power over me. They're not going to hire or fire me, and I can, you know, I often get into debates with them, and it's fine, and you know, they respect me, and I don't think it's as and I'm not sure what it's like in private practice in the United States. I don't have good insight into that.
I can tell you. So
I'm a bit worried about
all right, 2 minutes. We'll
getting
wrap
back
up.
to the
But
program.
when I was in a group that did their own cases, no nurse anesthetist, built good relations with the surgeons, a lot of flexibility for dialogue, supervising, very not optimal relationships, because you're not doing the case, and the model in the US is mainly supervised. But final point to you, yes, I agree, day of surgery, anesthesia, shouldn't be talking about that. What I mean is a dialogue with surgeons about the model, about surgeons and anesthesiologists agreeing about taking into account the anesthetic issues and how necessary is their surgery.
Well, yes, but the problem is that, you know, the way that surgery works in many countries at the moment with fee-for-service is that surgeons and the hospital and anesthesiologists are incentivized to do cases. So the incentive do the bloody work, you know, not figure out ways to do what's necessarily best for the patient. There are bizarre incentives in our society that don't always necessarily work in the patient's best interests. And you know, we justify it to ourselves, and we say, oh, we are doing what's best for the patient, but we're often not doing what's best for the patient. And you know, advocacy is complicated in an environment with specific financial incentives.
Right, that was fabulous.